Well, welcome and thank you for joining us today for our webinar, The State of Rare Autoimmune Disease in Women. I'm Serene Gulmamine, Associate Director of Research, Translation, and Programs at the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. Autoimmune diseases occur when the body's immune system mistakenly attacks its own healthy cells and tissues. And more than 80 autoimmune diseases have been identified, with women being disproportionately affected, accounting for approximately 3 out of 5 patients diagnosed with autoimmune conditions. Many autoimmune diseases are also classified as rare diseases, defined as conditions affecting fewer than 200,000 people in the United States. Despite their significant burden on women's health, rare autoimmune diseases remain underrecognized and under-researched, contributing to gaps in understanding disease mechanisms, diagnosis, treatment options, and long-term management strategies. As part of SWHR's autoimmune program, we are highlighting the current state of clinical care, research, and policy impacting women living with rare autoimmune diseases. We are pleased to have our panelists joining us for today's public forum in recognition of National Health Awareness Month. Dr. Alexa Miera from the Ohio State University Wexner Medical Center, Jennifer Waldrop from the Rare Disease Diversity Coalition, and Kania Gunter from Unique Guidance Nutritional Health Coaching. We also want to acknowledge that one of our panelists and rare disease working group members, Holly Jones, had an unexpected emergency and is unable to join us today. We are grateful that Kanaya, who also represents Her Story in Color in her board capacity, has graciously stepped in to join us and bring an important perspective in today's conversation. I would also like to thank the sponsor of today's event, Johnson & Johnson. SWHR maintains independence and editorial control of our program development, content, and work products. We will be live tweeting during this event and invite you to use the hashtags hashtag SWHR Talks Women Health, hashtag SWHR Talks Autoimmune, and SWHR Talks Rare on social media. We are excited to celebrate National Health Awareness Month. During August, health organizations, medical professionals, and communities unite to spotlight a wide spectrum of health concerns. This month is dedicated to educating people about preventative care, early detection, mental wellness, nutrition, exercise, and chronic disease management. It's also an opportunity to address healthcare access disparities, promote healthy behaviors, and foster supportive environments where everyone can thrive. National Health Awareness Month offers an important opportunity to bring greater visibility to rare autoimmune diseases in women, an area where significant gaps in awareness, research, diagnosis, and care persist. Autoimmune diseases collectively affect approximately 8% of the US population, and with 60% of people living with an autoimmune disease identifying as women. For women living with rare autoimmune conditions, the disparities can be even more pronounced, and several demonstrate particularly striking sex differences. Women are affected by cold agglutinin disease and Addison's disease at nearly twice the rate of men, while autoimmune hypophysitis can be 3 to 8 times more common in females depending on the subtype. Rare autoimmune diseases can also intersect with women's health across the lifespan, from menstruation and fertility to pregnancy, postpartum health, and menopause. Greater awareness and research focused on these differences are critical to improving recognition, accelerating diagnosis, expanding treatment options, and ensuring that the experiences of women living with rare autoimmune diseases are reflected in research and care. I'd like to welcome Dr. Alexa Miera to kick us off with the clinical complexities of recognizing and diagnosing rare autoimmune diseases in women and opportunities to strengthen multidisciplinary care and research across the lifespan. Thank you for joining us.
Hello, hello. All right, give me 1 second as I share my screen. All right, I think that's working. Play from the start. All right. I know we have a panel and there's some great speakers. So I'm Alexa Mira. I'm a rheumatologist that actually lives in the world of oncology and the intersection of autoimmune and cancer. But I've spent 15 years in general rheumatology as a vasculitis doctor and a lupus doctor. And rheumatology is the center of autoimmune diseases in the sense of how do you diagnose and management. So autoimmune in women is a known entity. So I wanted to talk a little bit about this idea of medicine in silos and some of the complexities just of autoimmune diseases, irrelevant of gender, that in the current state of medicine in various different doctors with very different niches and different expertise, it seems a little bit like the knee bone is no longer connected to the hip bone, right? That you have to see a knee doctor and a hip doctor. And so it's really hard and complex, as a patient, if your complaints are joint pain and fatigue, or rash and fatigue, or I just don't feel well, like who is the doctor to help you with that? And how do you navigate to those questions? And humans are really a sum of more than their parts, right? There is our immune system that floats around. We have all sorts of different things. And so no one is asking everyone to be on this phone call, on the Zoom, to be a rheumatologist, but it's just the idea that our silos are no longer serving us the way that I think they were once intended to flow. Oh, on my next slide, sorry. So this is sex hormones matter, and I know that sex hormones have become a huge political thing, and we're not going to talk about any of that, but we're going to just talk about in general this science behind some of the sex hormones of just in general estrogen, testosterone, and kind of what they do. Estrogen is actually quite protective. There's a reason why most women do, like, it's really unheard of for women to have gout. It can happen, but it's really rare until they are postmenopausal. Cardiovascular disease very much changes in women after postmenopause. Bone health, different things, pauses postmenopause. So estrogen does a lot of different things. There is estrogen in all genders, right? And so it floats around, there's various different levels. And so it's really important how we understand what estrogen does. And there's a huge amount of immune responses to all of these hormones. I think some of the difficult thing with this is we don't know how to measure that exactly. And there's no like perfect number. It's not like diabetes that if you have an A1C or your sugar is higher than here, then you have to go on this number of drugs. We don't really understand the fluctuations of hormones, when to measure them, when to replace them, and all those kind of things. We kind of just know if they're there or they're not there. We don't really know all of those complexities and then how they play with every other system in your body to that understanding. So immune systems, particularly estrogen, is really, really important in terms of the regulation of your immune system. And so that's why there's actually a study looking at lupus in female mice, and if you do not allow the mice to go through puberty or mature, they will never develop lupus, and these are lupus prone mice genetically. If they have any estrogen, then they develop lupus. So we know that the estrogen plays a role here. The question is, we don't really quite know how in the immune regulation and adding immune system different things and what they do here. And I want to say that despite that we know there's an estrogen connection, I've made it clear that I don't think we know the levels or hows. What also matters is who you are genetically and how that matters, and then what happens to you over life. And so those are three factors that we don't know how to measure. We only really know how to screen in the sense of very definitive. We know if this gene causes this, but then other than that, we just know they're general trends, but we don't really know what to do with them. And so that's what really comes into this importance of autoimmune diseases and the difficulties. So like the rarer the disease, the less known about it, the more difficult it is to have a diagnosis. Again, I'm not trying to make everyone a biologist here in the immune system. I just want to make it clear that the immune system and sex hormones have an influence and a relationship. And that's all that I'm trying to show here, is that there are huge amounts, whether it becomes to cancer, whether it becomes to virus, whether it becomes to allergies or autoimmune stuff, that there is a whole role here that we're still learning and identifying in the system of medicine. And there's a huge opportunity to understand that. A perfect example is any of us that have children. We know that if you have multiple children, when a kid gets sick, like one of your children seems to be, when they have a fever, they get a rash. One of your kids that gets a fever and then they vomit. So children show their unique immune responses in response to infection. That plays out through the rest of their life in allergies, whether they develop immune systems and different things. So all of this matters, and it's really hard to capture. There's no one lab test, there's no one way to do that. And so this is kind of the idea of these things. Also, we know, to what we were talking about before, that there is a huge difference in autoimmune diseases in women than in men. There are certain diseases that are about 50-50, but the majority of autoimmune diseases are much more common in women. So we know that there's a role for sex hormones here. And that makes it very difficult, since we can't totally we don't know how to study that. But also, some of these symptoms are overlapping a lot, right? If you look at Sjogren's, which is disease of dry eyes and dry mouth and various other organs, but that's the most common symptoms, or lupus or rheumatoid arthritis with joint pain, it comes with either joint pain, rashes, fatigue, not feeling well, feeling like you have the flu, right? And then various other organs involved. So there's this core of I don't feel well. And then how we adjudicate what those symptoms are is a little bit of, that's the art of medicine. It is what makes it worse, what makes it better, is it persistent? What are the other symptoms with it, to be able to help us figure out, right, is it a virus? Do you have something else going on entirely, or is it an autoimmune disease? And so this is kind of the idea of connecting the dots, that unfortunately, no matter what type of practitioner you are, you now have to be an immunologist, whether you want to or not, right? So even in diabetes, right, with all of the GLP-1s, those are hormone replacements and biologics. In cholesterol treatment, there are biologics. And in cardiovascular disease, there are biologics we use. In infectious disease, so the more and more and more, every subspecialty is dealing with the immune system. If you're a surgeon, you have to deal with wound healing. Everything is related to your immune system and how that interacts with whatever you want to do. And so understanding various ways of the immune system and how they integrate, I think, is a little bit of a lost art, and we have a big opportunity here to think about it. And again, not making everyone a rheumatologist, but knowing when to ask for help, knowing that there's something wrong here and how to do that, because there's a huge play, right? So autoimmune disease just means your body loses the ability to know self. It thinks something that is your person, yourself, is foreign, and attacks it. And allergy is almost like an immune response it's not that it's attacking it, it just is irritated by it, right? And so it can cause more damage. That's asthma, allergies and different things. And then you have the immune system, why either cancer and some other things, or viruses that are chronic, that don't go away, is your immune system either fails to recognize something that's false, or it just is disordered. And so all of these diseases are at the heart of your immune system, and the immune system is based on who you are, right? All of your hormones, sex hormones and everything else, and then where and how you live your life, and everything's happened, and that there's no right or wrong way to do stuff in those ways. Like, your genetics and things just kind of happen. And so what we're here to kind of help is, how do we adjudicate these things, and what we need to know about rheumatology and some of these rarer diseases. And so in autoimmune diseases that are really rare, it becomes a lot harder to have clinical trials and registries, because if you only see one case in your lifetime as a rheumatologist, how do you create information around that one disease throughout the whole world and share? And so some of these is the anxiety, right, of both the practitioners, of how do you treat something, you don't want to hurt someone, the anxiety of the patient of, I know something's wrong, but I can't seem to find an answer. Also, I think this idea that you have to have a diagnosis or a very clear-cut answer to be treated. And I think that's also a false premise. Sometimes we don't exactly know what's wrong, but there are things to make you feel better and to treat you as we're trying to figure out these diseases. Because some of these diseases are really, really hard to diagnose, or they present like another disease, to be able to do that. Depending on where you live and whatnot, the social cultural constructs about being sick, not being sick, whether if you have like Behçet's disease is a disease where you have vaginal and oral ulcers, right? That can look a lot like, sexually transmitted diseases, but it's not. So there's a lot of stigma around that, right? How do you find the right doctor? How do you get in? How many doctors do you have to see, right? Not all doctors are created equal. how we understand what these interactions are, and then treatments here. So I think there's a lot to this slide about showing all the anxieties and different things. And I think it both happens for the patients and the practitioners on both sides. And so I think that's where those disconnects come in, because depending on how you come in. But this little slide of the rare autoimmune diseases over here, there's so many more. This is just kind of suggesting. So if someone's on this phone call and your disease is not represented here, don't you worry, there are plenty more. But, you know, the idea is to be curious. You know, if a patient's saying something's wrong, the question is, how do you validate and get to the root cause? And sometimes not having a diagnosis, but starting treatments can really help you get to a diagnosis. And so it's really that partnership and that journey about health and how to do that. You know, and this is the nice thing, is we know what we don't know. And the reason I have a picture of a cockpit here of a plane is it's almost like in medicine we figured out if we touch certain buttons on a plane, we know we can take the plane off more effectively, or we know the plane can fly, but actually what we don't realize is the plane is upside down. Like, we don't quite understand how everything interacts, so we've gotten so much better at better drugs, but we're still not quite sure how to interact everything. So the promise is, right, your DNA suggests we have a treatment, but we know we only understand so much, and there's multiple treatments, right? What is the right drug? How do we figure out the right to minimize the side effects and whatnot? And so I think there's a little bit of a disconnect, particularly in social media, of what medicine delivers and has an idea of. And I don't think we're quite there to the promise of everything yet. I think we've just scratched the surface. And the reality is, we know genetics are important. We don't quite understand how they totally play. We know that we have a lot of treatment options, and we just don't know always what the right one is for you. And that doesn't mean as practitioners we failed. It just means I have no map, and sometimes the insurance companies are really difficult to get the drugs that we think are best. And sometimes diseases change over time, right? Between menopause and not menopause, you've had a virus, life just happens, and diseases may pivot, and so the drugs that are needed may pivot. And so what I want people to hear is that you should trust yourself if you don't feel right. Like, that's really, really important, and I don't want to minimize that. And how we communicate what you don't feel well. And so sometimes it does feel like 20 questions. I know that when I sometimes don't know what I'm treating with a patient and I have lots of questions about what this disease is, it's literally, does it do this? And I ask a lot of yes, no. And what I'm trying to figure out is, where does that, your symptoms fit in a possible disease, and what are the possible treatments? Ask clarifying questions. You and your partnering physician or team should, right, should be curious, right? It's a journey. It's not a sprint. It is the idea that we are going to partner together to treat you, to allow you to live the best life. Now, that may be more meds or less meds, but it's kind of that collaboration. And I think that's what's really important. And I think that's, again, in the silos of medicine, has been a little lost. This is kind of, I created a nonprofit for the space for those at the intersection of autoimmune and cancer, because there is nothing there to do just this. That's kind of what I do. That's just, you know, that's my day to day. But on the larger level of women and autoimmune disease and diseases, I think there's a disconnect on what is being seen on TV and commercials, the reality of practicing, the reality of the insurance companies. And I think we have an opportunity to stay curious together to build better relationships. So everyone, it's a win-win for everyone, but particularly for you if you're suffering from symptoms or different things or autoimmune diseases. And that is the end of my show. And then I have to stop sharing.
Thank you, Dr. Mayera. Very much appreciate you kind of running us through that. Next, we'll have Jennifer Waldrop, who will examine disparities in systemic barriers affecting rare autoimmune diseases and their diagnosis and care.
Great, thank you. So similar to Dr. Mira, let me go ahead and pull up my slides here. Okay, great. Thank you. Thanks for having me on today. Appreciate it. Welcome, everybody. I see that we've got some folks international as well. So hopefully you're enjoying your Friday evening or so. So I'm with the Rare Disease Diversity Coalition. I'm Jennifer Waldrop, the executive director. I think Siren mentioned that earlier. And so I wanted to share with you a little bit of a different angle from what Dr. Mira mentioned. We are a coalition made up of patient advocacy organizations, um, including SWHR, for example, along with biotech pharma companies, hospitals, providers, etc. So when you think about the patient that's a part of our coalition, sort of their whole ecosystem, we touch many of the folks that would they'd be involved with, including hospitals. We have relationships with the FDA, NIH, and that kind of stuff. So our angle has been around some of the original research around some of this work. And so I wanted to share some data that maybe you all can resonate and see yourself in. And maybe there's some new information in here that helps either validate what you've seen or provides you some additional insights. So we are a pan-rare disease organization that's focused on historically marginalized and underserved populations. And here in the United States, when it comes to clinical trials and research, women are often not a part of that research. So, as I mentioned, the Rare Disease Diversity Coalition, we've been around for 6 years. We are part of another organization called the Black Women's Health Imperative, and that organization's been around for over 40 years. Our vision at RDDC is to live in a world where rare disease care is a standard of care for all. We want to ensure that patients receive equal access to diagnosis, treatment, and support. Again, like I said, you probably see yourself in some of this. Again, we are focused on historically marginalized patients because we know that the burden is compounded. You probably know that from your own experiences, but we also have data that shares some of that information as well. Many of you probably know that in the United States, when we talk about rare diseases, we talk about it in a 1 in 10 perspective, which means there are over 30 million Americans living with a rare disease. At the RDDC, again, we've been around for 6 years, so we have over 100 plus coalition members. That includes both some individual contributors as well as companies and organizations. And the data I'm about to show you came from a working group. So we have 3 working groups at RDDC, and this came from the patient and provider working group on this survey. And there are about 52 people that helped us with this data and the information that we collected. And before I show you that data again, just wanted to level set, and Serene did a great job talking about it through the lens of the autoimmune area. You know, there are over 10,000 rare diseases out there. Many of them are classified within the autoimmune population. Like I said, depending on where you are in the world, it will depend on the data set that you use, and recognizing we've got folks that are here from outside the United States. This data may resonate further with your own country and within your own area. And that's really important in terms of research, in terms of drug development. In places like Europe, we talk about that there are 1 in 17 people globally that are impacted by a rare disease. And so there's over 400 million people globally that are impacted by a rare disease. And so when I look at, again, some of the stuff that we've done in this space, when we think about it through the lens of the autoimmune area specifically, you know, there are over 80% or 80 types of autoimmune diseases in there. And Dr. Muir has shared a few of them. We know that autoimmune diseases remain totally under-recognized and under-researched for many of the things that my other panelists and speakers have already shared. And so that's so true for the general rare disease community. We know that there are significant gaps in disease mechanisms, in diagnosis. Dr. Mira talked about silos and how sort of the medicine world sort of started and then had a purpose, and now things have advanced and how science has advanced. It really does impact the diagnosis of patients. Unfortunately, in the marginalized populations, we find that their data is actually multiple years and multiple doctors. So what they find is that the data shows that if you are a woman, for example, and maybe you're a woman, a person of color, you'll actually have a ch greater chance of having a longer diagnosis, and you'll have a chance of having more doctors to see in order for you to actually get a diagnosis. Treatment options can also be a barrier and concern for the underserved populations. And then, of course, the long-term management strategies is a continual conversation that organizations like mine and ones that I'm part of and the coalition members that we have continue to discuss and have concerns around. So, like I said, we did this particular project, and one of our partners, which is the National Organization for Rare Disorders, I'm hoping everybody on the call knows who they are because they are the ones that started and helped us with the Orphan Drug Act here in the United States over 40 years ago, so that the pharmaceutical companies had some incentives, for example, to do some additional research on top of the larger diseases that they often do research around. So it was really instrumental that NORD helped pass that particular Orphan Drug Act. And so they are one of our coalition members. And a few years ago, in working with them, we recognized that there wasn't a large data set that was out there discovering the gaps and barriers that are experienced by medically underrepresented populations. And so we wanted to work with them because we're a younger coalition, and using their experiences and some of their resources, we were able to reach out to patients and caregivers. And because we're focused on underrepresented populations, we wanted to be sure that at least half of our data set came from the broader definition of diversity. And so after putting together the questionnaire, having it sent out, mostly in the United States, but of course some folks did uh, were able to access the data, and so folks shared some of their information if they came from Canada, from England, that kind of stuff. And we took that into consideration as we were analyzing the information. And then we actually released the actual report in August of 2024. And so this is available on our website on the RDDC page. So what we found in that data set is when we think about it, and again, because we're a pan-rare organization, we did get some folks that called out that they had autoimmune diseases as well. And so we knew that some of this information would hopefully be relevant to you all today. So I'm not sure if you knew this, but 72% of rare diseases are genetic in origin. A lot of autoimmune rare diseases, I would say, are not, but there are quite a few that are. So you may be thinking that you are either a part of this group or maybe not a part of this group, depending on your situation. 45% of the respondents from our data set said they never received any kind of genetic testing. So that's not surprising, but it's also very concerning. Again, these are parents and caregivers. And again, because many rare diseases are inherited, from the children's perspective, we have the caregivers, for example, helping to answer some of these questions. And then 85% of those that were diagnosed were never offered a genetic testing. So, if you have respondents that never received a genetic testing, that's one thing. But even not being offered the genetic testing is very troubling. So, historically, these marginalized communities, they're less likely to be referred to genetic testing and counseling, and therefore they're more likely to face delayed diagnosis. And so, as I referred to before, a woman and a person of color, for example, of which I identify with, I'm more possibly, it's possible that I'm less likely to be offered this and then to face delayed in my diagnosis, because if it's genetic based, then perhaps if I can get that diagnosis sooner because of genetic testing, then obviously I can start getting my treatments and to hopefully start to mitigate some of those symptoms I'm feeling. I am going to talk a little bit about exome and genome sequencing and some of the work that we are doing here at RDDC, because we know that if you do some of the sequencing, if you're able to get some of these testings, then that can lead to a diagnosis a little sooner. And that would obviously be really helpful in terms of how you're feeling, and able to continue with life in a different way. I also want to call out that here in the United States, we have a Genetic Information Non-Discrimination Act. And I think that's really important to know because there are some communities and some groups that feel like that there's some concerns around testing and having some healthcare tests. So this law was passed back in 2008. And this idea of the act is that it protects people from discrimination, of course, based on genetic data that's collected. And so the health insurance and employment should not have any kind of bias against you because you've taken your genetic testing. It also covers your family medical history. And so, therefore, we're trying to protect folks from unfair treatment in your health plans and in your workplaces. So, as many as you know, in the United States, we depend on our employer to help us with our health insurance. We don't have universal health care, for example. And there are health insurance rules that are pertain to this that they have to follow. You cannot deny the coverage. Insurers cannot deny the coverage to healthy people based on the genetic risks. There are no price hikes to come along with this, and they're not forced to do any kind of testing. Plans cannot require or request people to take genetic tests, for example. And like I mentioned, there's a tendency to think that there's some sort of bias, but employers with 15 or more workers, because this was set up from the EEOC here in the States, you cannot use the genetic testing for making considerations for hiring folks, for firing folks, or promotions. And so workplaces are banned and barred from asking people for data regarding their genetic testing or buying the genetic information. Maybe that's some new information for you all. And of course, we try our best, and everyone does to try to do the best in terms of privacy. So collecting the data must be collected and kept really confidential. If you've never done genetic testing before, and if you're curious about how it works, we've advanced the science over the years, and really the doctors, you go to a lab, and the doctors take a blood or saliva sample, and they're able to sequence a specific gene if it's inherited or if it's part of genetics, to look see where you are if you're suspected of a rare condition, for example. Some tests are used to diagnose a molecular piece on the molecular level, and where you can where you can be specialized, and they go through it and they do the specific testing at these laboratories. And then ideally after that, you want to meet with a genetic counselor so that the testing that you've done is better understood, right? So you're not just getting a bunch of numbers and a bunch of information that obviously scientists and doctors are the ones that can understand that. So if you're curious about, what kind of diseases are genetic based, for example, I'm thinking of one in particular of a patient that I know that I've worked with really closely. It's called the autoimmune polyendocrine syndrome type 1, which is called APS1, and it is a obviously autoimmune. It is an autoimmune disease. It is considered rare, and this is one that is focused around autoimmune. It is genetic based. So, in this case, they actually need to inherit it from both parents historically, and you may have some symptoms if you only have having it from one parent. But for the most part, in order for you to actually have most of the symptoms, it needs to come in from both parts. And there is an autoimmune regulator gene in your body that it tests for to see if you have um, that that particular gene mutation, for example. So that one's called APS1. As I mentioned, we are working on genetic testing and sharing with the communities that it is available out there. It's available through insurance. There are referrals that you would get from your doctor. At RDDC, we put together a Breaking Barriers initiative where we are informing folks about the genetic testing. Where we've got some information on our website, social media. We're putting some things together with different webinars to educate our community around the importance of genetic testing, asking for genetic testing, perhaps even genome sequencing as needed. And what we want to do is we are working with these labs so that the navigation process is also culturally relevant. And so we want to ensure that you have a good experience with this genetic testing, with following up with the genetic counselor, and then that there are resources to support you with your results and how to navigate our healthcare system, specifically here in the United States. So that's called our Breaking Barriers program that we have going on with RDDC. In terms of some, and that's a result of the data that we collected from the survey. In terms of some of the other data that we found, which does impact the autoimmune community and it does impact women, is that what we found is in the underrepresented populations, which we would consider women to be a part of, a quarter percent of, or a quarter, 25% of the data that we collected, many of them could not afford prescription medications. And that includes also dental care, also about 25%. But then, of course, as we know as women, in many, many societies, both here in the United States as well as globally, so much of the care, sits on us. And so it's not surprising, I think, that managing care responsibilities is really high. And then if you identify in the LGBTQ community, there's a footnote here that it's even higher in that community. Of course, from the caregiver's perspective, and many women, right, are caregivers. There's more women generally as caregivers than men, for example, for just doing the binary there. The financial situation has worsened since they've become a caregiver, and then they themselves, their health is affected by the care situation. So if you're on this call and you are a caregiver for somebody living with an autoimmune rare disease, for example, I'm sure this data really resonates with you. And it's important to know because in the past we didn't have this actual concrete data. And if you can use this concrete data to tell your story and know that you are not alone in this, I think that really resonates and speaks volumes. If you're wondering, because I talked about the cost of Medicaid and what have you, well, if you're wondering about the cost of the folks that are actually a part of the study, yes, a number of them had health insurance, right? A number of them unfortunately had Medicare denials. So Medicare is our government insurance here in the United States. And so for those that are a part of that, for the older population in general, they were denied some of their care. And then Medicaid is available to folks from the lower socioeconomic status. And so for those folks, they were also denied. And I call out specifically that the denials were higher for the underrepresented populations. Wanted to also call out a little bit about, we talked about doctors and some of the importance of doctors being a part of our diagnosis, our treatment, our care team, and absolutely genetic testing, disease education, all of that is a part of the whole ecosystem, as Dr. Muir mentioned. And so working with your doctors is really important, and there's definitely opportunities and gaps there. We also at RDDC encourage folks to recognize that there are certain doctors that have more cultural competency than others. So finding a practice that can understand who you are is really important and not easy to do. But hopefully with some telehealth opportunities, it's maybe getting a little easier. So we also encourage folks to either continue with education for doctors in the cultural competency place as the world is getting smaller and becoming more black and brown, for example. And we do want to make sure that obviously from the specialty medicines, that these medicines also work for all people. And so as I get ready to wrap up, just wanted to let you know that RDDC has some resources out there. We've partnered with some other organizations in some of these resources. The Patient Advocate Foundation, for example, is one of our partners, had intentionally set up a rare disease care line after joining the Rare Disease Coalition, knowing that rare disease patients have and need different care than other types of diseases. We also have partnerships with NORD, and NORD has a huge breadth of database along with state-by-state directory that offers programs on mental health, housing, and other assistance on their website. And then if you're familiar with our caregiver partner called Rare Givers, they used to be called Angel Aid. They also offer a number of community groups and supportive tools for rare disease caregivers worldwide, and they have their materials translated in many different languages. If you want to follow us, we do policy work that you can see on our website. So lastly, thank you so much for including me in today's session. If you'd like to stay connected and check out our website, here it is. I'll pause for a second. I'll let you grab that, therarediseasediversity.org, or a screenshot, and then I'll just stop sharing.
Thank you so much, Jennifer. I will now be inviting Kanaya to come on to share the patient perspective on delayed diagnosis and self-advocacy, emphasizing the importance of representation in patient-led communities.
Hello, everyone. Thank you for having me. I'm so happy to be here on today. Cyrene, you did a great job of introducing. My name is Kanaya Gunter. I am Vice President of Her Story in Color. I'm also a patient advocate living with myositis and the founder of Unique Guidance Nutritional Health Coaching. Today, we're going to be talking about the patient experience in living with rare disease, why this conversation is needed today and beyond. So rare diseases, extend beyond clinical definition. It's a daily experience. It impacts your family, your community, your identity, and decision making. Next slide. I don't fit into one category. I exist in full color. Yes, most definitely. While living with autoimmune disease, I think it hits us head on with our health, which is, the patient living with rare and chronic illnesses, autoimmune diseases. It shows up with lifestyle, lifestyle and making those everyday life choices and through habits. It could affect the daughter, the sister, the wife, the mother, the relative, and friend. And purpose, founder, advocate, author, media host, and community leader and volunteer and nutritional health coach. So trying to find a life of purpose also while living and being diagnosed with autoimmune disease. Next. Rarely heard. So horses, you see here, you see the zebra, and you also see the unicorns. With the horses, you see the common conditions, rare diseases, and the unicorn, you see the rare within rare. Living with common conditions, rare diseases, chronic illnesses, autoimmune diseases, and those comorbidities, which are multiple conditions that could affect your health and also complex health conditions. I want to take a moment right here just to share a little bit of my story as far as to while living with myositis. And so taking a glimpse in my life, I always sometimes have to describe my journey in 3 words. In 3 words, I will say that at the beginning of diagnosis, I was living in fear. And in the present moment, just trying to believe that things will work out and having some hope. And thirdly, I always present as far as to the future and those outcomes and what it actually looks like to live with an autoimmune disease. So in that case of looking and having a better outlook, I chose to live on purpose. But in living on purpose, it also comes with the beginning of diagnosis. It affects you in all areas of your life. It affects your mental, your physical, your emotional, and your spiritual. I was a single mom with a child living with cerebral palsy. So, with illness, I still having to be a caregiver. Then it led into me having a lot of complications and symptoms, which, I suffered from fatigue, hair loss, difficulty breathing, myositis. It affects people from your juvenile myositis to polymyositis and dermatomyositis NXP2 is what I actually have. It's more prevalent as the conversation continues in women of color. It is found in men. In my case, while living with myositis, I was early on diagnosed with MS. I was diagnosed with lupus, and it took 3 to 5 years to actually find a myositis specialist, and which led me to having to travel out of network to Baltimore, Maryland, which is 4 hours away from where I'm actually living. In that case, when having to travel out of network, and suffering from financial, burden and hardship. I found that through it all, I had to do what I had to do while living with illness. In 2008, I became pregnant with my son, and happened to see a high risk doctor, and just following up really, really closely I knew it was much bigger than just me. It also took me in partnering with local doctors and those doctors that was out of network. In that, I learned that through treatment and medication, that I also had to, do what I had to do on my end, which led me into taking more of a holistic approach and partnering with my doctors, doing the research, which is so very, very much important, and finding a community, of a like-minded tribe to, so I can be able to cope, and also hear other patients' stories. And to be able to just raise more awareness and education around autoimmune diseases and myositis as a whole. So it do take a village, I always say, when it comes down to living with autoimmune disease, taking better care of yourself and taking more of a holistic approach. We talked about health, lifestyle, and living a life of purpose, which is so very important. You are not your diagnosis, so I wanted to share just a little bit about my story and just to encourage someone on today, that you are not what has happened to you. You are actually who you chose to become. So thank you for allowing me to share pieces of my story. You can go to the next slide. So living rare means managing multiple specialists that you heard me discuss, medications, the fragmented care, care coordination, family responsibilities. Healthcare definitely becomes a full-time job. Next slide. All right, so fragmented care and what that actually looks like. Providers, sometimes they don't always communicate. The patients coordinate their own care and being proactive and showing up for themselves and just being a voice in the room. Gaps in education, terminology, and technology, talking about the impact and the frustration and the burnout behind just wanting to just show up for yourself every day and just to feel better. It's sometimes leading to isolation and delayed care. The system often relies on patients to bridge gaps in their own healthcare. Next slide. All right, so we're talking about the intersectional challenges, dismissal of symptoms, lack of data and representation, lack of provider and the familiarity, economic inequalities. Women of color often face these challenges. Next slide. So what needs to change? Well, coordinated care teams. In that, we want to discuss about shared communication, support patients, not burden them with care coordination, train providers on multiple condition care, and integrate lived experience into education, which is one of my favorites too. While living on purpose, it led me to becoming a community health worker and joining the board and being vice president of Her Story in Color, so we can continue to raise awareness and educate the community, our family, and our friends. The next slide, please. All right, so maternal health and rare disease. So let's talk about the gaps in reproductive counseling, poor coordination across care teams, support for parenting while managing illness, support for raising child caregivers. Next slide. Medication reality, fear of stopping treatment, fear of harming the body, lack of clear guidance. Well, harsh reality and lack of clear guidance. The first option given is not a plan for a family. The second option given is to have an abortion. So having more discussions around, as far as to the reality of behind medication. Next slide. Why this matters? Well, sharing why this matters, rising diagnosis in women during childbearing years, while living with rare and those autoimmune chronic diseases, higher maternal risks, mortality and complications, and talking about those comorbidities. Well, and then lastly, we're talking about generational impact. Next slide. Reflections. A patient's life isn't just black and white. It's full color with depth in every shade. And as you see here, her story in color, I think we have every color that's up here. We're most definitely dedicated to making sure that we focus in on all autoimmune diseases and especially women that are living with these autoimmune diseases and other underlying conditions. The next slide. Right, and community informed. Her story in color, we're focused in on community informed, focus on women of color with complex conditions, advocacy, awareness, and we're talking about that equal accredited care. We believe in being the voice and the echo. And thank you so much. The next slide. Thank you so much for joining us.
Thank you, Kanaya, so much for walking us through the patient experience and highlighting her story in color and kind of your journey as a caregiver and also as a patient. I'm going to invite the other panelists to also join us on screen so we can do a little bit of quick Q&A as we're coming up on time. Just to kind of start us off, I would love to hear just a high level, what is one opportunity you feel that could be beneficial to shorten the path from symptom onset to accurate diagnosis? And I'd love to hear that from each of the panelists.
Do you want us to go in order? Is that
Sure.
easiest?
Yeah,
Okay.
that's yeah.
I was like, there's no right and wrong. We can go backwards order. It does not matter.
Either way.
I think that I'm gonna say two in one sentence. It is to trust yourself and to stay curious. I think you should be able to advocate for yourself as well as be able to stay curious that whatever preconceived notions, whether you're a practitioner or a patient, may not be the accurate to where we are in an ever-changing space that we need to. So if we can stay curious, but also trust your gut, right, and advocate for that.
I love that, Dr. Muir, and I guess we'll go in order. So, on that note, what I find in the community I work with is it's a little bit challenging because after being told, no, no, or it's in your mind for so long, you start to think that maybe it is, in your own head. That being said, there are patient advocacy organizations out there. Granted, there's not 10,000, like I mentioned, for the rare diseases, and there may not even be 80 for the 8 or so autoimmune diseases that we've talked about. But there are some that perhaps, if you are so fortunate to be diagnosed, there may be a broader group that's a part of that particular disease that you're a part of. So if you think maybe a little bit bigger, Behçet's, I think, is an example of that. That's a part of the Vasculitis Foundation. So maybe you do need to go a little broader. So I would say that if you are feeling knocked down a little bit, there are support groups and other resources out there that if you haven't turned to them, perhaps you should turn to them. And the data shows that most people don't actually go to patient advocacy organizations, and that's a shame because we are here because we think about the patients and we're creating resources and research because of the patients. So my big takeaway is if you haven't reached out to a patient advocacy organization, perhaps you could give it a try.
All right, I guess I'll jump on in here. So most definitely starting by doing the research and just following up and getting to know and educate yourself first. You heard me share pieces of educating yourself and family and friends, but don't be afraid to be the voice in the room while speaking with your doctor because there are resources out there. Sometimes closed mouth don't get fed. And so just making sure that you are, asking the questions. And if you feel like you're not asking the right questions, bringing someone else in the room. In most cases, while doing the research, some things are not accurate. But, joining the support groups and, learning from each other and listening to those patient stories, I think that gives you access as a patient. Most definitely. And just wanting to learn more in all areas is so important.
And I think you all kind of sum this up also with the next question that I want to ask, which is, we have a diverse audience, and that kind of spans across the, the population. We have patients, healthcare providers, researchers, industry, policy professionals, um, and kind of I'm interested to hear from each of you if you had one key takeaway or one thing that you want people to leave this webinar knowing or understanding better what that might be.
I feel like we should go backwards now.
Kanaya, if you feel comfortable kicking us off.
I think the key takeaway that I would want someone that's on today, newly diagnosed, that's still going through the journey, is most definitely just building their stuff up to, not being afraid to ask for help, because time is ticking, and at the end of the day, while time is passing, and we talked about the years of waiting for it to get a proper diagnosis, and just working with the correct team, I think asking for help is so very important. It leads you into focusing more on your health, focusing on your lifestyle, and making those changes around good quality of life, and just living a life of purpose and enjoying life. I think that is so very important. So those are my key takeaways.
I guess I'll go next. I'm in the middle. I would say that being attending webinars like this is a really great start if this is a way for you to collect information, but there's so much more out there, obviously for you to understand and to to be educated on, I guess, for the learnings. But then I think it's also the practice. And so if you take away from today conversations, in terms of perhaps the lived experience of patients, maybe you learned something new there. The experiences of the generalization of the survey that we collected, that not everyone obviously is the same, which we all kind of know that. But how does that show up in the way that we interact with people, and how does it show up in the way that we actually listen to others? And then thinking about it through doctors are human beings. They can only do so much. And so, really working with your clinicians and your providers in order for you to hopefully feel better and understand that there are gaps in our system. And so, getting a level of understanding of that can perhaps also help you provide a little bit of empathy to the situation, knowing that obviously it's not a perfect situation. And so, I would say continue to learn and then use those learnings and apply it to what you need to do in order for you to thrive and maybe even to cope.
Well, the fact that I have to go next after both of those is difficult. They've said a lot of really great things, and I think it's really important. Health changes over time, it is not static. And there is not one lab test, there's not one thing that defines that. And I think as your journey moves through, I think the thing to take away is that um, there is a disconnect again in what I think the medical system wishes to provide and its functionality to be able to provide it in a timely fashion, just due to bureaucracy, billing, all sorts of things and infrastructure that we wish didn't have to be there. And so I'll go back to the statement of trust your gut and stay curious. Because if you can do those two things, it will be figured out. It just may take longer than we want it to.
I think you all surmised it excellently, and I cannot even begin to express how much we appreciate having you all come to educate everyone from your different perspectives. So thank you to our panelists for your time and expertise, and thank you to Johnson and Johnson for their support of this webinar and SWHR's autoimmune program. SWHR will continue this conversation online and across our work to improve our understanding of rare autoimmune diseases in women. And so we encourage you all to visit our website to access free resources, including policy agendas, fact sheets, toolkits, and webinars. And in addition to our website, you can also connect with us on social media to register for future events, download women's health resources, and to sign up for our newsletter. We will send out an email with the recording of today's webinar to all registrants, as well as post the recording on the events webpage for future viewing. So please be on the lookout for our webinar and feel free to share with others as we continue the conversation with SWHR Talks Women's Health and SWHR Talks Autoimmune. Thank you for joining us.